prostate itself is a gland, and it's a reproductive gland. So it's useful in men in reproductive ages, you know, their 20s, 30s, whatnot. And so it's about the size of a kiwi. Later in life, it grows, and it sits under the bladder along the urinary stream path. And so it can block the urinary stream. But also later in life, it can get cancer inside of it. And so 1 in 7 men are diagnosed with prostate cancer within the course of their natural life. And that's the most common cancer in men. At very late stages, symptoms it can spread and cause symptoms like pain or blockage of the urinary path so that people can't urinate. But early on, it's actually a silent cancer. We really can't find any symptoms. So the way we diagnose it is through screening. And screening is done through a blood test where we check for something called PSA. And PSA is made by the prostate, and it's only made by the prostate, but prostate cancer makes more of it. And so if someone's PSA is high, then we have suspicion that they may be at risk for prostate cancer, and we can do some diagnostic workup to try to figure out if they do or not. Not a lot of known causes for prostate cancer. You know, there's no known environmental causes or exposures or anything like that. But people ask me, you know, what might have I done, or what can I do to prevent it? And there's not a lot known. Having said that, prostate cancer is associated with the race, and so it turns out some races get more prostate cancer, some get less. Asian cultures tend to get less. African American cultures tend to get more. The other predictor of prostate cancer is family history. So a first-degree male relative, essentially a father or a brother with prostate cancer, increases your risk of prostate cancer as well. There's one extreme where it's extremely slow growing and is unlikely to have any effect in the natural life of that person. And so the person may be diagnosed with cancer when they're 60, but they may be able to live until they're 90 and die of other causes and not do anything about the cancer. So on that extreme of low-risk cancer, we talk about active surveillance, where all we do is we keep a close eye on the cancer. We might do extra studies such as MRI to image the cancer, and MRI-guided biopsy to sample it, and genetic testing to also get a sense of how aggressive the cancer is. But if we're assured that it's not aggressive, then we just keep an eye on it, checking once a year to make sure it's not showing signs of early changes. There are slightly more aggressive cancers, such as like an intermediate risk cancer, where it's still localized to the prostate, it's not spread throughout the body. And for those situations, there's a lot of effective treatment options. There's things such as surgery, especially robotic surgery. I do a lot of that kind of work where it's minimally invasive, and we go into the belly and we essentially disconnect the prostate from everything else and take it out and reconnect all the urinary tract back together, essentially. And so there's radiation, and there's other treatments out there that are still being examined, such as HIFU, high-intensity focused ultrasound, cryotherapy, where we freeze the prostate. Even some types of focal therapy are now being experimented with, or we're working on types of focal therapy to destroy part of the gland that has tumor in it, but not destroy the whole gland, and that may help with some of the side effects. The decision for testing and screening is done when you don't have symptoms. A lot of men are afraid to screen and look for it, but this is a very treatable disease. And especially with a lot of advances that we've made, even if you're diagnosed with prostate cancer, that doesn't mean you're actually going to get surgery, get radiation, get anything. But it's better to know what you have, if you have any issue, and stay on top of it. And if you do have something, then catch it early so it's treatable, rather than late stage where then it becomes harder to treat.